I really never thought I would start doing this surgery, but there's some other procedures I wanted to offer women, and this was the technology I needed to be able to do this kind of higher level complexity of care.
Welcome to TPMG Health Talk, where medical experts from Tidewater Physicians Multi-Specialty Group explore the health topics that matter most. Discover more at mytpmg.com. We're joined by Dr. Jeffrey Morrison, a board-certified obstetrician and gynecologist with nearly 2 decades of experience in women's health. Dr. Morrison has been with TPMG since 2003, providing comprehensive care across all stages of life, with special interests in maternal health, minimally invasive gynecologic surgery, and pelvic floor conditions. He practices at multiple locations, including Newport News, Hampton, Williamsburg, and White Marsh. In addition to his clinical work, he serves as Chief Medical Informatics Officer, leading initiatives to integrate technology and improve patient care. Thank you so much for joining us.
My pleasure.
So you've been with the company for a long time.
Yeah, I came in September of '03. So what is that, 22 years?
That's wonderful. Well, we're appreciative of your time. How do you feel your approach to patient care impacts the health of the community, especially in women and families?
It has a major impact, obviously, because it's women's health, and especially with pregnancy, we're providing care for the lifetime breath of a woman. I think about younger women with birth control and STD prevention. Obviously, that's a huge impact. Like, it can help prevent challenges that might occur if you had an unwanted pregnancy. Also, obviously, educating women about sexually transmitted disease or infections and avoiding those, and also get them comfortable with the idea of seeking health care, feeling comfortable with health care. It's, God forbid you create a phobia in a young person's world. I think back to my own personal experience with a dentist. So when I'm taking care of patients, especially younger women or even women who haven't been seen for fear of what the unknown and everything else, I mean, it's just a really challenging but a great opportunity to help someone experience something that they're going to need to do for their betterment of their health care for the rest of their lives and not create that phobia. So when it comes to younger women or patients having their first experience with a gynecologic exam, I take it really seriously. And then with pregnancy, pregnancy in the United States, unfortunately, women of color have a higher incidence of death and morbidity with pregnancy. And so that's near and dear to my heart, taking care of everybody and treating everybody the same. Obviously, that's our goal. And then trying to figure out, what are we doing that we could be doing differently for women of color so we can make sure they don't have, a bad experience or in their healthcare journey, in their pregnancy. And then coming at it from I'm a Caucasian, I'm a man, and knowing that I have my burden is to provide care to everybody and to do a good job at that. So we've had a great opportunity at TPMG because we have the midwifery program, which has been shown in studies that every patient involved has a lower incidence of preterm birth. And we went through our centering program where there's they think that the reason that helps people is because they come together and they get prenatal care in a group therapy environment, so to speak. And so it's not really like the regular coming in, see a patient for 15 minutes, and then try to educate them about what you can about their pregnancy. And then, they follow back up in a month or so or 2 weeks or what have you, depending on how far along they are. This is more like a degree in pregnancy and prenatal care. And so it's a wonderful experience for our patients. And then the fact that they get an exposure to other women at the same gestational age or the same length of the pregnancy they're in, and they kind of communicate and hear everybody else's questions and the answers. And it's been shown to reduce the, kind of anxiety around pregnancy and reduce the birth rate, both preterm birth weight, low birth weight. And that's one thing that I love that we're able to offer at TPMG, OB/GYN. The other component is there's some screening tests that we have worked hard to make sure we incorporate into every single patient's care, that hypertension in pregnancy, which is called preeclampsia, and then can result in eclampsia, which is a seizure at the time of pregnancy. If you screen patients and you figure out that they're high risk for that, then the 81 milligrams of aspirin once a day from 12 weeks on till delivery can reduce that risk. And it's like the only thing of all the things I've done in my career, which has been, as you pointed out, not insignificant length, it really is an opportunity to help. So that component of our care and having, it's so easy to identify the problems and the challenges of care, but having solutions that you can offer people that are meaningful, like the aspirin screening, it's just been wonderful. And then when you progress from there, mammogram screening, huge when you consider 1 in 8 women in America develop breast cancer, having that opportunity and then the ability we have here at TPMG because we have our imaging center with our 2 board-certified mammographers who do a wonderful job, and we can keep it all in-house because we have, MRI, and we can do the biopsies, we can figure out what the next steps are. They often will see someone and identify an issue, and they can do the follow-up screening with both ultrasound and diagnostic mammogram and then MRI if needed. That's been just a wonderful opportunity for my practice and the patients that we're able to take care of. And then from there, I think moving into kind of menopause and the opportunities we have with hormone replacement, that we're able to educate patients and offer a wide variety of solutions that can really makes a difference. So when you mention it for the community, usually it seems like I'm in Costco is where I see all the people that I've ever taken care of. And, it's a joy. And I do have, as an OB-GYN and a man, I don't approach anybody unless they recognize me. Kind of like my teacher when I was a kid. Like when I saw her outside of school, I wondered how they let her free. But I see patients in the community a lot, and it's a small community, and I do think the opportunity we have to provide care and make a difference has been a wonderful part of my career.
Well, you mentioned it earlier, and there's a conversation around gender dynamics in OB-GYN care, with some patients feeling more comfortable with female providers for such intimate health issues. As a male OB-GYN, how do you approach building trust and comfort with your patients?
As a male provider in women's services, I do try to develop rapport. I don't want to make anyone uncomfortable. I always have a chaperone with me, female chaperone. It's always just a conversation, and my idea is just take care of someone. So it doesn't, I just want to, be able to kind of communicate on the level that they are ready to communicate with me on, and make them comfortable. And I really use like humor as my main foil, just to make people comfortable. Occasionally someone will say, well, oh, you can't, you wouldn't really know what it's like because you're not a woman. And I'm like, do you think the surgeon who takes out your appendix, would you not feel comfortable if they hadn't had an appendectomy? My training is to take care of you. My personal experience would probably be more biased than it would be helpful. So I said, also, I can never say to you, hey, suck it up. Like, I can take care of this, because I can't. My respect for a woman's ability to carry a child and undergo all the things we have to undergo, like I have utmost respect. I can never say, hey, what's your problem? This is easy, because I can't experience it.
Well, you mentioned the disparities faced by minority populations. What other specific challenges do you see in communities when it comes to accessing quality health care?
Fear is definitely an issue. Some patients, they just don't want to know. Maybe it's human nature. Like they're so fearful of, what if I have cancer? Well, what if I have cervical cancer, breast cancer? I just don't want to know. I can think of a patient I saw in Williamsburg, in our Williamsburg office the other day, and she came in for a problem, but then as we kind of got to talking, and I just find people fascinating and I love to talk. So she's an aircraft mechanic. But then slowly, as we kept the conversation going, she admitted to me she hadn't had a pap smear in like 10 years, and she never had a mammogram. And so women, they're the last to seek care sometimes, just because they're so busy taking care of their family, their kids, their husband, their adult parents, that kind of thing. So I have a lot of times when patients come in with that. COVID was definitely an impact. I have patients still coming back post-COVID. They just didn't seek care. They were just petrified of getting sick, or they were exposed, did develop COVID and had problems, and they just couldn't bear the thought of getting it again. So that's been a little bit of a problem. Access to care, and that, sometimes that's insurance-based. Sometimes they can't get in anywhere. And then occasionally patients have some certain problems that maybe the provider they see initially just doesn't really engage with them and recognize what's wrong with them, and then offer the possibilities of care that they could have. I've had a few patients who, definitely in the menopause range, where they might see a provider and the provider would actually just maybe not engage and not listen, and then instead of offering, because of maybe this provider's preconceived ideas about hormone replacement and the safety of that there's like, hey, this is your part of your life, and this is kind of what happens, and like, almost like, hey, that's normal. And when they find their way to my partners or myself, and we're like, oh no, we're, there's a whole lot of options we have here to treat you. And my partners and I, we all do robotic surgery for disease states that require surgery, like hysterectomies and those kind of things. And occasionally in the area, there are people who don't offer the same level of different care. So a woman with a certain size uterus, someone who's probably not doing robotic surgery or even not doing laparoscopic surgery, at some size they would say, look, you're going to have a big incision. You're going to be in the hospital for multiple days. And so I can think of a patient who came in with a big uterus with heavy periods, remote from being menopausal, where it would all stop, and saying, look, before I could even start having a conversation, she said, I don't want a hysterectomy. And I was like, well, can we, let's talk about it. Let me just describe when I do a hysterectomy, or my partners do a hysterectomy on someone, like, this is what we do. We do it laparoscopically. You don't spend the night in the hospital. We don't make any big incisions. You go home the same day. This person's like, are you kidding? Like, the person I spoke to before said I'd have to have, I'd be in the hospital 3 days. I'd have a big incision. It'd be vertical. It'd go from my belly button to my pubic bone. And Mary Immaculate, where my partners and I operate, they have what's called the Da Vinci 5, DV5. It's an intuitive Da Vinci surgical robot. And it's not like C3PO, or it's not like a Roomba. Like, they don't put you to sleep and then I press a button and I would go have coffee and I come back and it's done. it's basically just a tool. So we tell everybody we're using the robot to do the care because it is newer, but it'd be like me telling you I'm going to use a scalpel to do your C-section. Like in that concept, the robotic surgical experience it's the tool I use to be able to do the surgery. But it's really phenomenal, like the ability that we have with the robotic surgery, like the view we get inside a woman's abdomen and the ability we have to control the instruments, because we control the camera, we control the instruments we're using. And actually, it gives me the ability to have like 4 arms, because when I do most of the cases, I have a camera and 3 arms, and I can alternate between which ones I'm controlling during the procedure. And it's really been just a wonderful part of my career that I really never thought I would start doing this surgery, but there's some other procedures I wanted to offer women. And this was the technology I needed to be able to do this kind of higher level complexity of care. And it was wonderful. Like my partners and I have all been trained, and the team we have at Mary Immaculate is excellent. And our ability to offer this care that's really minimally invasive and converts like what could be considered a multiple day admission away from your family and away from your spouse, and then ultimately back to something where we can safely do a surgery and send you home the same day, and you're starting your recovery quickly instead of spending the night in the hospital and exposure to germs of the hospital and being developing a DVT in your leg as you've been laying in a bed. It really is it's really an opportunity for us to help take care of patients in a minimally invasive way.
Yeah, it's amazing the technology we have now. Do you ever find the need or find the necessity to go back to kind of the old ways just so you're not, what if there's like a power outage or something? I think about that sometimes. I'm like, yeah, all this robotic technology is cool, but don't you have to use the old school way sometimes?
Yeah, that's a good question. Technology's definitely been helpful. And yes, there's definitely safety in the system. They've thought of it all. I mean, they're designed that if you have a problem, we can, even if there's a power outage, there's instruments we have in the hospital with robotic equipment that we can manually undo. Like if we have an instrument that's holding something inside the abdomen, like we manually can undo it and remove it without power. The safety is there, okay. So that's not an issue. And then when it comes to OBGYN, for example, cesarean sections are this is a really common surgery we do to deliver women. Fortunately, with our midwifery program, 85% of women deliver vaginally, and only 15% need a C-section. Assuming, I'm speaking specifically of women who are the most ideal patient to have a vaginal delivery, so that the baby's head is down and they don't have any other complications, and they're at term in pregnancy, so at 40 weeks or around that 37 to 40 weeks. So it's 85% vaginal and then 15% C-section. So C-section, there is no robot, there is no technology. It's like, other than lights and then, anesthesia either, and the vast majority with a spinal or an epidural for pain relief. And so, yeah, we still have a component of our kind of old school, so to speak. And then we also still, assist the midwives with vaginal delivery. So all that stuff in medicine is still the same. But I do like the technology we have to help us provide better care in those other ways. But at the end of the day, I mean, medicine's so personal. So ultimately, the interaction we have on a person-to-person level, that's the key. And that's not changing, and it never will.
You mentioned menopause earlier, and despite being such a common experience, menopause is often misunderstood and overlooked in conversations about women's health. What do you wish women understood more about this stage?
Gosh, that's a good question. It is, it's hard to kind of think back to when I didn't know about this, women's health and even the human body and that kind of thing. I think there's a lot of confusion about it, and, for no fault of anybody's particular, like when you're learning about women's health in high school and as you go into college and are doing biology, it's not, think about the age when we educate women about their bodies. It's like, it's so irrelevant in a way. You might hear it and, you listen to it, but it's not really relevant to you. You're 16, 15, 14, like what, menopause? A lot of women will come in and say, oh, I'm going to have a hysterectomy, then I'll be in menopause. And so kind of going through it with folks is like, ultimately when menopause is when the ovaries stop making hormones. So the ovaries don't know what else is going on in your body. So you have a uterus, you don't have a uterus, the ovaries don't know. So, if you do have a hysterectomy, but your ovaries remain in place, you don't go through menopause until you would naturally go through menopause, which in the United States, it's like 52 and a half is kind of average. So a lot of folks come in and they're 40, they're 30, they're like, I'm having these hot flashes, I think I'm in menopause. And that's, and I get it, like why, and that is a thing, you could have premature menopause, but it's pretty uncommon. And usually folks are like, I'm hot all the time. And so what happens when a woman's stops making estrogen, her ovaries stop making estrogen, then the peripheral vasculature of the chest all the way up to the scalp, it becomes less regulated. So people all say flash, which somehow got into the lexicon of the lay public. But what it is actually a vascular flush. So another example of a flush that people would understand is an embarrassment. So a hot flush is when the vessels of the, from the chest up can dilate quickly at the surface of the skin. And so all the blood, which is in your core, 98 degrees, comes to your skin. And it causes you to feel hot because that's where the sensitivity of our bodies for heat is. And then it also causes you to sweat. And so all those vessels dilate. You get this flush of, a vascular flush, like being embarrassed. All that area you get really hot. You start to sweat, and as quickly as all those vessels opened up, they close. And so then the sweat evaporates, and then you feel cold because now all the heat that you felt before has now become cold. Water evaporating or sweat evaporating causes cold. So it's a back and forth flush experience that happens can be like 30, 40, 50 times a day. And a lot of people experience at night. That's kind of what the biology of what's going on. Our bodies definitely start to change as we age. So sometimes in their 40s, patients start to experience like some changes that could be related to like changes in the hormone levels. So folks will come to see us and we can test for all that. In my practice, we do offer hormone replacement therapy. And a lot of women are actually starting to seek testosterone therapy kind of in that transitional phase, maybe from, whatever age to menopause. And we do have that therapy option that we can provide people that's safe and effective and can really helps with libido. It helps with energy. It helps with muscle mass, helps with bone density. We do offer that for patients as they kind of transition in their lives from, being like 20 to being like 40.
Are you still accepting new patients?
Yes, we are. We have 4 offices, so it's Newport News, Williamsburg, Hampton, and Gloucester. And then we have 3 physicians like myself, Dr. Cordes and Dr. Tan. And then we have 6 midwives who help us with OB care and some gynecologic care. We have 6 nurse practitioners who also help us provide care. Wonderful women, all these folks I mentioned, they're just utmost professionals. I feel lucky to get to work with them on a regular basis. We meet regularly. We talk about clinical practice and we talk about specific patients. And so it's a wonderful working relationship we have across our 4 sites.
We talked about menopause. Now let's talk about something many women are reluctant to discuss, bladder control and pelvic floor health. I know that's something you specialize in. Are these extremely common?
Very much so. Yeah, it's a common problem that a lot of women have, and it really can be any age. And so, the most common thing folks have is that they have stress urinary incontinence. And basically when people like laugh, jump, cough, sneeze, and then they may leak urine, maybe a little, maybe a lot. So because of knowing that that's a problem, that I just make it a habit of asking every patient every time, hey, do you have a problem with this? Because there's options for therapy that can help make a difference. And so when you look at a lot of studies, which as I'm getting older, I do, about longevity, what's been shown that's consistently finds that people live longer in their lives. And one of the things that's consistent across most studies is being social. And so when you think about a woman as she gets older, or a man as they get older, like if you're having problems like with leaking urine, or if you're incontinence of whatever kind, it's going to change your social habits, especially if, God forbid, you're widowed and then you're having those kind of problems. You're just not necessarily going to go out because you don't want to be somewhere and be embarrassed. It is a huge impact on people's lives. And so I make sure I ask everybody about that. So for stress incontinence is the most common thing. And there's a lot of different reasons that people can have that. And most commonly it's being pregnant at all, but, vaginal deliveries can increase that chance. And so, we offer pelvic floor physical therapy that we can refer patients to pelvic floor physical therapists. And, actually TPMG physical therapy has someone who can help with that. We also refer folks to other, Bon Secours has In Motion, which has pelvic floor physical therapy. So that's where people go. And these are female provider physical therapists that help women figure out exactly how, engage their core. There's some biofeedback they can do so they can help people strengthen their pelvic floor and understand kind of why they might be leaking when they cough or sneeze. There's a couple different surgical procedures that I do and the urology partners here at TPMG do. And those are simple outpatient surgeries that don't take very long, and they give support under the urethra. So when a woman coughs or sneezes, the urethra kind of drops while it's trying to stay closed, and it will bump into this little support we put in, and that'll be a solution. So when a woman coughs or sneezes, she won't leak. When she needs to urinate, there's no problem. And there's also a bulking agent now that's out on the market. It's very common in Europe. It's not as common in the United States. It's called Bulkamid, made by a company called Axonics. And it's like, when you think about people getting filler in their lip, like it's actually a filler you inject in the urethra, and like these 4 little spots. It's a very simple procedure. It doesn't take very long, and it basically creates a little bit more bulk to the urethra. And so when you need to urinate, no problem. But then when you cough or sneeze, it's bulkier and you don't leak. So those are all some options we have for people with stress incontinence. Now from there, there's definitely pelvic organ prolapse, which would be where, hate to think about it, but, it freaks people out when you talk about it. But occasionally a patient will come in, the support of the vagina and the cervix and the uterus is gone. And so everything that should be inside is actually exteriorized. And so one of the surgeries I mentioned earlier about why I chose to go beyond laparoscopic surgery to do robotic surgery is there's a procedure called an abdominal sacrocolpopexy. Huge word.
Wow, say that 5 times fast.
Right. So basically what it is when someone has a pelvic floor prolapse, so either if they've had a hysterectomy and the vagina is like exteriorizing, or if the cervix and uterus are exteriorizing, then the best way to solve that problem is to support that with a system that we attach to the sacral prominence. And so the term I gave was abdominal sacrocolpopexy. It's done and through the abdomen, so that's the abdominal part. The sacrocolpopexy, sacro refers to where we attach it. It's the sacral prominence, which is on the inside of the abdomen, but it's where the sacrum is in between the hips. So there's a spot that's above the vagina where you can support everything up. It keeps everything from going out, and it allows the vagina to move inward, but it also lets it move side to side. So we just need it to not go out anymore. And so that's what this procedure provides. And then so sacrum is where we attach it. Colpus refers to the vagina, and then pexy is any kind of lifting procedure. Basically, we have a system that we attach to the vagina and lift it up and attach to the sacrum. And then that way, people don't have pelvic organ prolapse anymore. So that's been a really rewarding surgical procedure I do. And I have to use the robot for that because it does take a lot of steps, but it does keep people get them back into regular, kind of life. And there's a range of women who have this problem, even younger women who are after childbearing, it's becoming a problem for them to be able to function. And this is the procedure we do to, solve that issue long term.
Does it start with incontinence and then go to pelvic floor, or you can have either?
You can have either. Stress incontinence can be an isolated issue without anything else wrong with the connective tissue that supports the vagina, the cervix, and the uterus. And along those lines, like 50% of women who have pelvic organ prolapse, when you you repair the prolapse, then about half those women will have stress incontinence. With the prolapse, the way the bladder's being kinked because the bladder's fallen, so the urethra is actually kinked. You don't realize you're having a problem because when you cough, the uterus pushes out further, and then the urine can't really get out of the urethra. It's like kinking a garden hose. But when we put it back up in the right place, like half folks, they just don't have the support at the urethra to stay closed. So when they cough in the new position of the vagina, then they actually leak. So we test ahead of time and verify, are they going to be at risk of that? So if they are, then we do the surgery all at the same time, where we do the sacrocolpopexy and we give the urethral support, and then we try to avoid them having to come back for a repeat surgery.
Now let's shift to a hot topic that affects many older adults, specifically Medicare. How does Medicare impact access to preventative and specialty care for women?
Medicare provides for access to care for women. The guidelines around screening for cervical cancer, they change in the 60s. So we just know historically that when women are at risk of developing cervical cancer, and if a woman's had normal pap smears, by the time she's in her 60s, she doesn't really need to continue to get pap smears for cervical cancer screening. There's definitely a transition in women's expectations of when they go to the doctor. So we've got better understanding of cervical cancer risk, and we have better understanding of the screening technology we have available, and it's improved, and then HPV screening. And so we definitely have changed what we're doing. So probably for the beginning of my career, we were trying to encourage people to come every year, and then fearful that people weren't coming in and people were developing cervical cancer because they weren't getting screened. And then now we've kind of flipped the script on people because now our testing is a little better, and so we still recommend patients come be seen every year, but actually coming to be seen and examined and getting the actual pap test they're separate things. So people confuse like the pelvic exam, where we're looking at the cervix, looking at the vagina, making sure everything's normal and there's no abnormalities. And then in that process, we have a decision to make. Do we need to screen them for cervical cancer or do we not? So the pap smear screening, if you're high risk, then we definitely should be screening every year. Certain age women under 30, it's a little more the higher risk. And so screening is more important. And then as women get older, and if they've had multiple negatives, and if they're low risk of cervical cancer, which is usually monogamous with no previous history of abnormal pap smears or HPV, then we can spread out the interval of pap smear screening. And then at 65, it's not recommended if you don't have any risk. So a lot of patients just saying, we're happy to see you, absolutely, but do you need to come get a pap smear screening or even a pelvic exam every year? You don't. We have a lot of patient education because, this 65-year-old today, when she was 35, she was ingrained in her by basically her mom saying, you got to go, make sure you get your pap smear. And now, 30 years later, 35 years later, things have changed dramatically. And they're like, what do you mean? You don't want to give me a pap smear? So access, it just depends. Every office kind of does their own thing as far as who they're willing to see. And then, Medicare reimbursement varies, and it always comes up every year with the Congress and like how much is going to be reimbursed for things. And so that creates a little bit of a barrier for people. But at our office and at TPMG in general, we see Medicare patients. We educate them about why we're seeing them. We're happy to provide their care. There's no barrier, at least at TPMG, and definitely not at my office. But it can be hard to find providers that are still providing care to Medicare patients once they switch from their previous plans to Medicare.
Well, we're glad that you are available as well as your partners and other providers. Before we close, many of our listeners might be interested in joining TPMG's mission to support community health. Can you share what kind of career opportunities are available for people that want to be a part of the TPMG team?
Absolutely. Providing care to patients. I mean, it's the gambit of things that you could think of, from people at the front desk checking people in. Folks are making phone calls to remind patients to come have their visits, answering when it comes to like clinical things, answering triage calls, making sure that's available for them, helping us in the office to, pre-authorizations. So there's both clinical and administrative. And then beyond just in any individual office at TPMG, we have programs that we are working with Medicare and Medicare Advantage to try to reduce costs, provide better care for patients, and meet clinical guidelines. And so we have a group of women at TPMG that there happen to be women, we could be men too, but there are 7 of them that work with TPMG as a whole and helping close these care gaps for patients like colonoscopy, mammogram, making sure that their folks are being compliant with taking their medications for diabetes and high cholesterol. And that group of folks is available, and they're really important. They reach out to every patient when they get discharged from the hospital, the ER, or a skilled nursing facility, and they make sure that they follow up with their primary care provider. The opportunities that we have to help with longevity and help patients stay out of the ER, stay out of the hospital is broad. And, we offer that at TPMG because we are primary care based. And that CMS or Medicare, they recognize the value of seeking primary care services, and that they know that if you have a primary care provider that you see and that you think of them first when it comes to your care, then ultimately you're not going to be receiving unnecessary care or frequently going to the ER or being hospitalized. I mean, those things that can be managed in the outpatient setting, we're in an excellent position to do that. And then this group of people that I mentioned, the care coordinators, the 6 of them, they help with that. And they're an extension of the primary care offices to help our patients get seen. And then the offices themselves have staff that reach out to help with that. We have a program at TPMG. It's called Advanced Primary Care Management. And that once a Medicare patient or Medicare Advantage patient enrolls in that, it's a monthly review of the patient's record. And it's any care that they've had, phone calls, refills, referrals. And then if they've had it or not, then the primary care provider looks at their chart once a month and makes sure everything's going the way we anticipate, and see if they need any care that we've missed, if maybe their mammograms due or they have a refill of their thyroid medicine or something like that. So that's all what's available at TPMG for our patients, and we need anyone who can help with that, which you could, as I mentioned, it could be the person answering the phone or a nurse or an MA, a phlebotomist. I mean, we have ultimate opportunity. And then people can start at some positions and they develop the skill set and they move up in the administrative roles from phone answering to billing to being an office manager, an assistant office manager, and the same, for staff who they join us as an medical assistant, and maybe they go back to school, become an LPN. And then, there's just an opportunity to grow inside our company.
To find your place at TPMG, visit mytpmg.com. Thank you, Dr. Morrison, for sharing your expertise with TPMG Health Talk. And make sure to subscribe if you haven't already. Until next time, take care.
The information shared on today's podcast is not intended to be medical advice, nor is it meant to replace a professional consultation with a healthcare provider. The opinions expressed in this podcast do not necessarily reflect those of TPMG or its providers and physicians.